Welcome to this resource on Tetralogy of Fallot. We'll cover information you might see on exams and have 5 practice questions at the end with rationale. But first, let me welcome you to Artemis Interactive Media. Artemis is your guide to learning resource supplements and content overview for continuing education. This quick timeout is a short study break and we'll cover Tetralogy of Fallot, but don't worry, if we need any help, Artemis will be here to guide us. Tetralogy of Fallot is a congenital cyanotic heart defect. It causes right to left shunting and leads to decreased oxygenation to the body. Considering the defects involved will help you determine anticipated symptoms and the interventions. There are 4 defects. TET means 4. The first is ventricular septal defect, pulmonary stenosis, an overriding aorta, and right ventricular hypertrophy. We're also going to cover the memory trick PROVE. PROVE covers the 4 defects plus an E. The P is pulmonary stenosis. Stenosis is narrowing, so we have narrowing of the pulmonary valve, which is the outflow tract. Narrowing makes it harder for blood to get to the lungs. This leads to decreased oxygenation. The R is right ventricular hypertrophy. We have thickening of the right ventricular muscle due to increased workload. The right ventricle works harder against the narrowed pulmonary valve. There's also an overriding aorta. The aorta is positioned over the VSD, ventricular septal defect, which receiving blood from both ventricles. This allows mixed oxygenated and deoxygenated blood to enter the aorta. The V is ventricular septal defect. This is a hole between the right and left ventricle. This allows blood to shunt from the right to the left, especially with increased right ventricular pressure. The E is really not a defect, but in this case, everything causes cyanosis. All 4 defects lead to right to left shunting and decreased oxygenation in the blood. This results in decreased oxygen delivery to the body, causing cyanosis and risk for TET spells. Pulmonary stenosis increases right ventricular pressure. Blood shunts through a ventricular septal defect. Deoxygenated blood enters systemic circulation. The mixing of deoxygenated blood with oxygenated blood going out to the body causes poor perfusion and cyanosis. Signs and symptoms include cyanosis, clubbing of the fingers and toes, poor feeding, failure to thrive, and squatting, which is a compensatory mechanism used to increase oxygenation. TET spells can be triggered by crying, feeding, or stress. It causes sudden cyanosis, severe hypoxia, and it's an emergency situation. Nursing interventions for TET spells include putting the child in a knee-chest position, administering oxygen, keeping the child calm, providing morphine if prescribed, and administering IV fluids. Diagnosis is made by echocardiogram, chest x-ray, ECG, pulse oximetry, and you might note a boot-shaped heart. You can note on this image the rounded shape on the normal heart and the boot-shaped heart of Tetralogy of Fallot. You'll see right ventricular hypertrophy and concave pulmonary artery. Treatment includes oxygen. We give supplemental oxygen to improve oxygen levels. Propranolol. This medication is used to reduce the workload of the heart. We give IV fluids. We provide fluids through the vein to maintain hydration and support circulation. And surgical correction to fix the heart defect and improve blood flow may be needed. Nursing care includes monitoring oxygen saturation, assessing feeding tolerance, allowing rest periods, and monitoring growth. Parent teaching involves recognize TET spells, use knee-chest position, adhere to medication regimen, and follow-up care. Some key takeaways include blue baby, squatting as a compensatory mechanism, and TET spells. The acronym PROVE is used for the defects, but it's also used for how to care for the child. The P is position. Place the child in the knee chest position to increase oxygen to the lungs. Relax. Keep the child calm and minimize crying. Oxygen. We give supplemental oxygen as prescribed. Ventilation. Ensure open airway and adequate breathing. And emergency help. Call for help. Activate emergency response if there's no improvement. And once again for the defects, P, pulmonary stenosis, R, right ventricular hypertrophy, O, overriding aorta, V, ventricular septal defect, and E, everything causes cyanosis. It's time to test our knowledge. Tetralogy of Fallot can be a complicated topic to understand. It causes a systemic effect and requires different treatment considerations. The following questions will test our knowledge on the material we covered in this resource. So let's answer the following 5 questions to gauge our mastery of this material. Don't worry, Artemis will be here to help us if we need her. Question 1. A child with Tetralogy of Fallot becomes cyanotic and restless. What should the nurse do first? Lay the child flat, use the knee chest position, encourage walking, or restrict oxygen. Artemis is going to help us out and say B, the knee chest position. Can you give us some rationale? The knee chest position is a priority intervention during a TET spell because it increases systemic vascular resistance. It decreases right to left shunting and improves pulmonary blood flow. This helps increase oxygenation quickly. Why are the other choices wrong? A, lying flat worsens venous return and can worsen shunting. C, activity increases oxygen demand. And D, oxygen should be given, not restricted. Thanks, Artemis. Question 2. Which finding is expected in Tetralogy of Fallot? Pink skin, bradycardia, cyanosis, or weight gain? I'm going to say C, cyanosis. Artemis is going to give us some rationale. Tetralogy of Fallot is a cyanotic heart defect because deoxygenated blood bypasses the lungs and enters the systemic circulation. This causes low oxygen levels and blue discoloration of the skin. The others are wrong because pink skin suggests adequate oxygenation, tachycardia is more common with hypoxia, and failure to thrive is more likely than weight gain. Thank you, Artemis. Question 3. Which defect is included in Tetralogy of Fallot? A, mitral valve prolapse, B, coarctation, C, atrial fibrillation, or D, pulmonary stenosis? I'm going to say D, pulmonary stenosis. Artemis, can you give us some rationale? Pulmonary stenosis is one of the 4 defects of Tetralogy of Fallot and is a major cause of decreased blood flow to the lungs, contributing to cyanosis. There is a memory aid proof. Pulmonary stenosis, right ventricular hypertrophy, overriding aorta, and ventricular septal defect. I add E because everything causes cyanosis. Why are the others wrong? A, C, D are not part of Tetralogy of Fallot. Question 4. What X-ray finding is common in Tetralogy of Fallot? Enlarged left ventricle, boot-shaped heart, fluid overload, or collapsed lung? I'm going to say B, boot-shaped heart. And the rationale is right ventricular hypertrophy causes the heart to appear boot-shaped on chest X-ray, which is a classic finding in Tetralogy of Fallot. The others are wrong because the right ventricle is affected, not the left. C is not a defining X-ray feature, and pneumothorax is unrelated. Question 5. Why do children with Tetralogy of Fallot squat? Is it to rest, improve oxygenation, stretch muscles, or reduce pain? I'm going to say B, improve oxygenation. The rationale is squatting increases systemic vascular resistance, which reduces right to left shunting and pushes more blood into the lungs for oxygenation. This naturally relieves hypoxic symptoms. The others are wrong because rest may help, but oxygenation is the main reason. C is not related to muscle stretching, and squatting does not relieve pain. Thank you for your attention to this resource presented by Artemis Interactive Media. This presentation may be used for content review and clinical competencies for pre-conference and post-conference education. This quick timeout can also be used for a short study break. Tetralogy of Fallot involves more than this cutie covers. For more information on this disorder, please contact your instructor and refer to your textbook. If you would like to review the references used in this resource, you can find them here.